We are Smiles Institute of Gastroenterology. Initially started small. In the last 5 years, we have grown very big in this country. When I tell Smiles Gastroenterology, Smiles Hospitals, people think it is a dental hospital. Actually, we make the other end smile. We are not a dental hospital, but we make the other end smile. So this is how we start our work. And so, in approach to colorectal problems, when we were doing post-graduation, undergraduation, the very common word used was bottom case. Even today, everywhere in surgical units or medical colleges or outside, they call it as bottom case. People have forgotten the mine is in the bottom. The gold mine is in the bottom. The platinum is in the bottom. And this is the area where mess is created by many surgeons across the country. And even I was one of them. Until I focused on this specialty, I was doing a mediocre, below average practice, making a lot of mistakes, spreading about 10 years time. Only after 10 years of making mistakes, when I started focus, we started finding results. Next slide. As we say, anus is the window to the gastrointestinal system. This is the term coined by our institute. I am sure Dr. Siddharamu here, surgical gastroenterologist, will agree. We don't treat anus properly. We don't respect the anus properly. Next slide. See, for example, a simple ulcer in the esophagus or a stomach can be a melena. A simple bleed in the small bowel can be a melena. A frank blood can be a colorectal cancer. A mucus can be a UC or a Crohn's disease. And a constipation can be an obstructive defecation syndrome where people don't diagnose and just load them with laxatives, maybe bulk laxatives or osmotic laxatives. And an actinomyosis in the anal canal can be mistaken for an hemorrhoid. So don't treat anus as spines, fissure, fistula or bottom. It is just beyond that. It can be UC, it can be Crohn's, it can be colorectal cancer, it can be polyps, it can be bleed in the upper GI. So for anything, small ulcer in the mouth also can be a Crohn's disease. So from the anus, you can peep up to the mouth if you know the symptoms well. Next slide. So, few patient stories to share. A medical student from Chamarajanagar Medical College, a bright student, brilliant, meritorious student, came to me with a perianal abscess. Generally, we follow a protocol for any perianal abscess. We will not touch without doing a MRI scan or a colonoscopy. I told this student to get a colonoscopy done. He was not convinced the way I was talking. He said, why colonoscopy for a simple abscess, sir? I don't want to get a colonoscopy. I failed to convince. Then I took it, undertaking that I have refused colonoscopy even though the doctor advised. Then I did a drainage, primary fistulotomy. He went back. Again after 2 months, he sent a message on WhatsApp, sir, I have an abscess, one more. You have not treated it properly. This is the word. I have the message even now. Then please come down, I'll see you once again. He said, I have an internal assessment. So please complete your internal assessment and come down. When he came, that time I convinced and we did a colonoscopy. It was a full-blown ulcerative colitis. A simple abscess. Then we did a MRI scan. He had multiple fistula tracts in the rectum, anal canal. Another story to share. Recently, last month, son of a doctor who owns a big hospital in Bangalore rural region. He had a perineal abscess, 9 years old boy, young boy, 9 years old, 9 years young. He's gone to his godfather surgeon and that surgeon, as usual language, hey, Adin Baraya, an injection he has drained the pus. Then the wound did not heal. Then he went to another surgeon and asked for a second opinion. He says, go to Parameshwara and please get him deeply evaluated. Then we did a colonoscopy. It was a full-grown Crohn's disease. We do deep ileoscopy in every patient who comes with abscess or a fistula. Another lady, after delivering 3 children, small stature, normal delivery from Tirupati, 3 children more than 3 kgs. After that, she had constipation issues. She had urge incontinence. She had stress incontinence. She has gone to 40 doctors, believe me or not, 40 doctors to diagnose what it is. She had constipation. So every single consultant prescribed laxatives, Prismovac, bulk laxatives, purgatives, Ayurveda, homeopathy, Pet Safa, everything she has tested. She came here, we went deep into her life. All the pre-deliveries were big babies, and during normal delivery, there is a pressure on the rectum and the bladder, and there is a pelvic floor descent. So when there is a pelvic floor descent, we have rectocele, both anterior and posterior, and a cystocele. Rectocele will give rise to ODS, obstructive defecation syndrome, and cystocele gives us stress incontinence and urge incontinence. So out of 10, 8 women who come to surgical OPD with piles, fissure, fistula, please go deep into their lives and ensure that you will take a detailed obstetric history. When you talk to them and ask them detailed obstetric history, you will see the lady will do a digital evacuation of stools, or she will put pressure on the anal canal, or move forward, go backward, go right, or go left, and stress and urge incontinence, repeated UTIs, going to various doctors, just getting antibiotics without being properly treated. So very clearly, any woman who comes to surgical clinic with piles, fissure, or fistulas, please go into obstetric history, spend time with the patient. Invariably, there will be ODS and cystocele, rectocele. So, another story to share. A young advocate came with multiple fissures. All his plan was come one day in the morning, go back in the evening, next day go back to court. Any multiple fissures in the anal canal, I am sure again our surgical GI, Dr. Siddharaman will agree, we will do a deep ileoscopy. Any multiple fissures, deep ileoscopy. I did a deep ileoscopy on this patient. We found Crohn's disease. Once we find Crohn's disease, we do a CT enterogram to see the transmural involvement of the disease. When we did the CT enterogram, along with the CT enterogram, we could pick up some periportal lymph nodes. Then we see periportal lymph nodes, we did a PET scan. PET scan revealed neuroendocrine tumor of the duodenum. A simple fissure, he came, and this was a diagnosis. Any pain abdomen should not be neglected. There are many cases in Bangalore, in corporates, big names in Bangalore city missed out colorectal cancers. Colorectal cancer is the only cancer in India which is diagnosed in the late stage. About 78% of colorectal cancers are diagnosed in the late stage when you can't operate them or treat them. Next slide. Now, what is the extent of problem with this colorectal problems in the country? About 30% of given population at this particular point of time have got some kind of colorectal issues like constipations, fissure, fistula, hemorrhoids, rectal polyps, or colorectal cancers. 36% of India's population at any given point of time. And 50% suffer at least once in lifetime. I am sure all the senior surgeons here would agree with this. Next slide. So where do these people go? Dr. Ravi was mentioning to me, sir, yako piles alla patients bartala kadame agibidide anta. Piles kadame agilla, jaasti aagta hai. Lifestyle modification. No sedentary lifestyle. Sitting for a long period of time on the desk and working IT. Eating junk food, eating processed food, packed food, kurkure, chips, lace, children, very bad habits. We don't see children playing at all now. Mobile phone, late sleep, and all these things have impacted our day-to-day life. Less physical activity, less water, less fiber, less sleep, and all these things have given rise to constipation, and people have don't go to surgeons. Previous slide. They don't go to family physician. They don't go to a surgeon. They don't go to colorectal surgeon. Where do they go? They go to quacks. With due respect to religion, with due respect to region, there are 1.5 million quacks in India published in European Journal of Colorectal Surgery. In European Journal it's published. 15 lakh quacks in the name of Piles Clinic, Bagandar Clinic, Fistula Clinic, treatment without operation, same day going home, multiple sittings, Muslims and Bengalis. You must have seen Muslim hoardings in every taluka, in every district, near railway station, near bus stations. 15 lakh quacks in the country. Why this 15 lakh quacks is? From times immemorial, in our country, we are all responsible for this because it was just treated as a bottom case. Bangalore Medical College, Mysore Medical College, Ballari Medical College. You see the surgical OT list 20 years back, 25 years back, 15 surgeries in the list. First was thyroid, second was breast, next was gingivectomy, next was gallbladder, next was hernia, next was appendix, and then bottom cases, last. Infect last Akyalka. Last cases, bottom cases, Bandara when they came, who operated? Not the prof, not the associate, not the assistant. By the time everybody would have left the theatre. Senior PG, boss of the theatre. Boss, junior PG, first year PG, waiting for a chance. Chance kodi sarandozda. Chance kotro on marda surgery without learning. Sphincterotomy mistakes. Abscess mistakes. Hemorrhoids mistakes. Hemorrhoids, anal canal stenosis. Just know what Dr. Gururaj was telling. Very badly operated hemorrhoid came with anal canal stenosis. He has referred the patient to me. So, first year mistakes, what a postgraduate did, what I did, I practiced for 10 long years after postgraduation before focusing on this field. So, we are all responsible because we never respected this colorectal work. They all ended up with quacks. They exploited, believe me, they are more richer, more wealthier than all of us sitting here. These Bengalis and Muslim doctors. Next slide. Common colorectal problems. Piles, fissure, abscess, fistula, pyeloneal sinus, though it is not colorectal, it lands up with the colorectal surgeon or a general surgeon. Rectal collapse, constipation, anal polyps, IBD, IBS, ODS, ulcerative colitis, Crohn's disease, colorectal cancer. See the spectrum of diseases. This is the spectrum where majority of the outpatients, majority of surgeries, secondary case surgeries, sometimes tertiary also falls in this category. Next slide. Common symptoms you all know: pain, bleeding, discomfort, itching, burning, difficulty in passing stool, chronic pain in the anal canal, where people neglect it. They will tell pain is there, anti-inflammatory, analgesic, laxative, and send without doing a digital examination. Digital rectal examination. The chronic pain is neglected everywhere. Stain with passing stools, first discharge, swelling, fever if there is an acute abscess. Next slide. So a wise physician said the best medicine for humans is love. Someone asked, what if it doesn't work? He smiles and answered, increase the dose. So the best medicine is love. If it doesn't work, increase the dose. I am sure you all will agree with this. Everywhere you love more and you get the patients. You love the patients. Spend time with the patients. You get the patients. Next slide. What for a surgeon? Told by Donald B. Effler, who is a heart transplant surgeon in the US. He says, to be a great surgeon, he or she must have a fierce determination to be the leader in his field. Whatever field you choose, be a leader in the field. He must have a driving ego. A driving ego for what? To be the best. A hunger beyond money. Hunger beyond money. If you go behind money, money will not come to you. A testimony is, I am standing here, we have earned a lot, we don't have hunger for money, money is coming behind us. Dr. Ravi Kumar was a witness in our hospital a couple of years back. He spent about 2 days with me in the theatre. And he or she is like the actor who wants his name in lights. Celebrity actors in the country. So they want their name to be lit up. Surgeon also, no? Lifesaver. a life giver, his name has to be, he or she should be lit up in the lights. Next slide. Next slide. So what should a general surgeon approach if he comes with patient with colorectal problems? I always said it's not just piles, fissure and fistula. Think beyond this whenever a patient of this problem comes to you. Think beyond that. Next slide. So a detailed history is very, very important. I spend solid 30 to 35 minutes when the patient come to me for OPD in Bangalore. Solid 30 to 35 minutes. I give life to them. And my consultation fee for a single OP, guess how much I charge? Any guesses? OPD consultation fee mine. But for the poor I give discounts. I know who's poor. Yes sir, any guess? I charge 3,000 rupees for consultation in Bangalore. 3,000 rupees for consultation. When a plumber can give 3,000, when an electrician can take 3,000, when a gardener can take 3,000 for a small work, why not surgeons put in 15 years of life behind doing MCA surgery? You put all together totally 35, 40 years of studies. 3,000 rupees we are not eligible. Yes, we are. We deserve it. Next slide. So, a detailed clinical examination. Examination of the perinatal regions. Detailed examination of the perinatal regions. Very, very important. The moment we see ignoring, will come out. Colorectal examination is mandatory. When we do a digital rectal examination, we just put the finger and come out. Don't do that. Spend some time in the anal canal. Palpate the dentate line for any tenderness on the dentate line, for any induration on the dentate line, where you may miss an intersphincteric fistula. Go deep. You will spend some more time. You may find a mass. You may find a rectal growth. You may find a rectal polyp. Next slide. So as I told, simple bleed can be colorectal cancer, ulcerative colitis, Crohn's disease, constipation can be obstructive repeat syndrome. Next slide. So this fistula, what I will be talking now, it is unpredictable. It never knows where it is going until it gets there. It is random. It will find its places in the anorectal region through the spaces. It is always growing and changing. It is never the same person twice. But one thing you can be sure about fistula, it will never be cured by Babas, Viswas and Badshahs. Dr. Ranjit, he coined this statement. He is a surgical gastroenterologist practicing in Bangalore. He is our colleague. Next slide. So Goligar, Bible of colorectal surgeries, he mentioned it is more difficult to operate a complex recurrent fistula than a rectal cancer. I am sure everybody will agree with this. Next slide. Many surgeons' reputation have been impunged because of consequences of a fistula surgery than any other surgery in the world. I am sure each one have come across recurrences. Each one of would have come across recurrent fistulas or a fistula after abscess drainage. Imagine the patient coming next to you. Doctor, bantalla madidira neevu. Queue hogta ide. One sari madri, ಎರಡು ಸರಿ ಮಾಡಿದ್ವಿ ವಾಸಿ ಆಗಲಿಲ್ಲ ಅಂತ. And he will destroy your name in his neighborhood, in his locality. Our doctor ಸರಿ ಇಲ್ಲ, ಸರಿಯಾಗಿ ಮಾಡಲಿಲ್ಲ ಅಂತ. So reputation of surgeons have gone because of fistula surgery. Next slide. Next slide. So what is the etiology of fistula? 90% of fistulas are due to simple cryptoglandular infection. 90%. It is that 10% which is a challenge and to diagnose. What are those 10%? Fistulas due to trauma, obstetric fistulas, iatrogenic fistulas, by probing causing fistulas, Crohn's disease, anal fissures. A simple anal fissure. When I tell the patient a chronic fissure will never heal, to undergo a surgery, fissure surgery ಮಾಡ್ತಾರಪ್ಪ ಇವರು ಅಂತ. After 3 months, 6 months, or 1 year, they have come back with abscess and fistula. Diverticular disease, tuberculosis, actinomycosis, carcinoma, radiation, chlamydial infections. So all these things are causes of fistula. 90% is cryptoglandular. 4% of fistulas in India are tubercular. 2% of the fistulas, if not treated for 20 years, 2% will change into squamous cell carcinoma. We have reported 7 cases of squamous cell carcinoma in the last 5 years in fistula, long standing from rural areas. Next slide. So pathophysiology. anal gland infection, perianal abscess, drainage or surgery, fistula formation. It will drain on its own by giving an antibiotic by practitioners, by family physicians. Giving an antibiotic is not the treatment for fistula, abscess. Never give antibiotic for abscess. Please take a bold decision and drain the abscess first. Next is fistula formation after you drain it. So this is the physiology of fistula. Infection, abscess, drainage, surgery, fistula. Next slide. So an abscess is a journey towards a fistula in ano. An abscess is a journey towards fistula in ano. So what are the key principles we follow while doing an abscess surgery is, we don't operate an abscess without doing an MRI scan. If it is a perianal abscess, fine. If it is a istiorectal abscess, if it is a intersphincteric abscess, if it is a supralevator abscess, we had it. We give trouble to the patient. So we do MRI scan for an abscess in all the patients. Next is abscess. During abscess, you can't do a colonoscopy. Once we drain the abscess, we do colonoscopy in all patients after 2 months when the wound is completely healed. We do go up to ileum and do a deep ileoscopy to rule out prawns. In case if there is no MRI scan in your city, in your hospital, how to handle this abscess? Always do under spinal anesthesia or a saddle block. When you put him in anesthesia, you will have complete control of the patient. Do a rectal examination, see in your eye and palpate it. You will find pus, a pit or a papillae on the dentate line. When you see that, when you put pressure on the abscess, you will see pus coming out. So that is the internal opening. That is the internal opening, and you see most prominent point. The mistake what was made by our surgeons was they tell put incision on the most prominent position and drain it. So if the fistula is istiorectal, far away from the anal verge, you drain there. Then if it develops a fistula, you will develop a complex fistula which is transplantic in nature. Next thing is, when you drain an abscess, what we have seen is they will put a crisscross incision, drain out the pus, put your finger and break all the locules. When you drain the abscess, put your finger, break all the locules in different direction. Right, you create one track. Up, you create one track. Left, you create one track. Down, you create one track. An abscess drained like this, when it comes back to you, it will be invariably a complex fistula in ano. And who are responsible for complex fistulas? 90% of the time, it is surgeons who will give complex fistula to the patient. And why? Because the drainage is not done properly. So you ask me how to drain them. What is the best way to drain them? Whenever you want to drain a fistula, the fistula will start in the dentate line, internal sphincter, intersphincteric space. From there, it goes to supralevator or istiorectal or perianal. So always drain close to the anal canal as possible, anal verge as possible. So way to drain, palpate the abscess, go towards the anal verge, in the intersphincteric space, palpate it, put the incision there. From there you drain it and the patient will not have complex fistula. If at all he develops a complex fistula, it will be a simple fistula. This is about istiorectal and perianal. Supralevator abscess and intersphincteric abscess. How do you drain? Go in the intersphincteric space from the dentate line. From there you probe it and drain the abscess from inside. This is how, if you don't have an MRI scan, under anesthesia, after doing an examination under anesthesia, you can drain the abscess from inside or from outside. From inside, it is in the intersphincteric space. From outside, it is in the intersphincteric space, outside palpate. So that's how we drain the abscess. Next is, after draining the abscess, we do the follow-up for at least 1 year to see whether the abscess, the fistula formation is there or not. I have published 236 perianal abscess 236 abscess cases. 236 cases, only one case developed a fistula. That too, he was a diabetic. We do a primary fistulotomy in every abscess. From the internal opening, we drain up to the abscess. Every abscess, we treat as fistula and do a primary fistulotomy. Next slide. So, you see this, these are the anal glands in the intersphincteric space, internal sphincter, external sphincter. See, this is the anal gland, an infected anal gland. Once it forms pus, it goes to the perineal space to form a perineal fistula, ischiorectal space to form ischiorectal fistula, then intersphincteric fistula. From here, it goes and forms the supralevator fistula. Next slide. Abscess, sorry. See, this is the supralevator abscess. This is the intersphincteric abscess, this one. This is the perianal one. This is the internal sphincter. This one. This is the external sphincter. This is the ischiorectal abscess. Next slide. Again, ischiorectal space here, external sphincter, internal sphincter, perineal space, submucosal space, intersphincteric space, supralevator space. So a very important thing is in operating a fistula and abscesses, pelvic floor anatomy, anal canal anatomy, anatomy of the internal sphincters, external sphincters, puborectalis, anorectal sling. This anatomy we need to know properly. I did not know anatomy properly. After 10 years, when I was in Mandya Medical College, I used to go to the mortuary and operate on the cadavers to know about the anal canal anatomy. Then only I got my surgeries right. Otherwise, I would always do the mistakes. Once you enter the anal canal, I'm scared where I will do a incontinence and I would do a 50% work and come out. Next slide. So this Parkes classification we read from times immemorial. Even today, in the belly, the same picture is there. But Parkes classification is not relevant anymore. Why? Just see this. Next slide. See, how will you classify this fistula? Will it fit into any Parkes classification? No. See this slide. This is a female. Previous one. This is a female. This is the male one. Next slide. See this. Complex fistula. So much. See, this indicates recurrent fistula. Operated earlier, the white patch where there is sphincter deficient, and this is a complex fistula. You can't fit into Parkes classification. Next slide. See this. This also can't fit into Parkes classification. Next slide. Look at this. A young lady operated in the US 3 times. Had 2 seaters and she came here. Which classification will put this? Next slide. Look at this fistula. Next slide. Next slide. Next slide. See, previous slide. Previous one. See, this is the female. Track, internal opening, 3 internal openings. Track going all the way into the vagina and she had a rectovaginal fistula. Next slide. Next slide. Next slide. See, come before. See this one. This is a lady with Crohn's disease. She had multiple openings in the vagina. She had multiple openings in the anal canal. The moment you see multiple openings, the moment you see multiple discharges, when you say, wow, you should suspect UC or Crohn's. Next slide. Next slide. Yeah. These are all complex fistula. Next slide. Next slide. Next slide. This is also again Crohn's. Next slide. This is a very simple fistula anteriorly. Any anterior fistula in any woman, we call it as a complex fistula because of less vascularity and less muscle. Next slide. Next slide. Next slide. Next slide. Next slide. Next slide. See, come back. See, this is a fistula where there was no external opening. This patient had a fistula with chronic pain and he always complained of tailbone pain. He went to orthopedic surgeons, he went to Ayurvedic massage, Ayurvedic therapy, finally came to us. When this patient came, I did a rectal examination and came out. I missed it. Again he comes back with pain. Dr. Ranjit examined him and he said there is a fistula inside. So this patient, next slide. Next slide. Next slide. Next slide. Next slide. Next slide. Next. 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 Why I showed all these images are, there are more complex cases with us than this. Park's classification is not relevant anymore, but still they follow in many parts of the world. In India, a surgeon is given a classification, even that will not fit into this. So, fistula classification, simple for basics, it is transpintry, interspintry, supraelevator, or simple fistula. Next slide. So, evaluation, detailed history, physical examination, routine investigations, imaging, MRI scan or endorenal ultrasound scan, and colonoscopy I mentioned. Mandatory in any fistula or abscess, we do colonoscopy in all the patients. Next, histopathic examination. Next slide. History is recurrent swelling, abscess, discharge, swelling, external opening, pain and bleeding. Sometimes chronic pain in the anal canal or rectum when there is a intersphincteric fistula in anal. Next slide. See, palpation around the perineum reveals induration around the tract. Sometimes when you don't see an external opening, when the patient comes with pain, spend time palpating the entire perineum. You will know there will be a tract or induration. Next slide. Digital rectal examination identifies areas of induration and coexisting anal rectal sepsis. Spend time in the anal canal, just not one place, on the dentate line, completely around the anal canal, do a proper examination and ask the patient where it pains. So the place where it pains a lot, that is the internal opening of the fistula, if there is no external opening. External opening in intersphincteric space or supraelevator fistulas, you will not be able to find. Next slide. So this is the one. See, there is no external opening. Fistula was going in the intersphincteric space, right crossing the levator muscles. This was the intersphincteric fistula again. Next slide. Same one. Now investigations. So whenever we come across a fistula or an abscess, I told you we will do a MRI scan for an abscess. Endorenal ultrasound scan. In an abscess, when you try to do it, it will be very painful. You will not be able to put your finger also. Imagine putting the probe of the scan. So in fistula, one of the best in the world, not one of the best in the world is Dr. Shankaran, Queen's Road. I am sure everybody knows him. But unfortunately, our fistula load went up so much, we could not get appointment with him for fistula scans. So what I did, I trained one radiologist in Bangalore, Dr. Lohan. His reporting is 100% perfect now. Much better than endorenal ultrasound scan. The only thing is little expensive. When you do an MRI scan, when you have a CD, take it to any other radiologist or take it to any other surgeon or a J surgeon, he will be able to read the fistula. But endorenal ultrasound scan is user dependent. Once it is done, he will give only the image over. You can't review the slides or you can't review the MRI images on a system or the films. So always now we practice only MRI fistulograms or a fistula in ano or an abscess in ano. Now, next slide. So investigations, when there is first for culture and sensitivity, CRP, ESR, vitamin B12, vitamin D, then magnesium, colonoscopy is mandatory, endorenal ultrasound scan or MRI scan. We prefer MRI scan rather than endorenal ultrasound scan now, and fecal calprotectin if there is ulcerative colitis or Crohn's disease. Next slide. Okay. Post-operative investigations, tissue biopsy, PCR, gen expert, lymphobasset to rule out COX. As I said, there are 4% of fistula cases are due to tuberculosis. So far in our organization, in the last 5 years, we have reported 82 tuberculosis cases. 82 tuberculosis fistulas. Then, after 3 months of fistula surgery, when it is completely healed, we do the anal manometry mandatory for all complex fistulas, for all recurrent fistulas, not simple fistulas, to see whether there is any problem in this defecation in getting proper pressures in the anal canal. Next slide. So post-operative care, after operating a fistula surgery, complete healing will take place in 6 to 8 weeks time. You should tell the patients to have patience, because in that place anything in the anal canal will take 6 to 8 weeks time. Thorough wash after moving the bowel is mandatory. Sitz bath, spelling mistake. Sitz bath with plain warm water for at least 3 times a day. Topical application of crema ano, combination of all the 3 products, analgesic, antibiotic, and our metronidazole combination. Then good nutritious diet, laxatives like cremafil plus, good physical activity. People tell after a fistula surgery to take rest. The next day in the morning, if I don't do a primary sphincter repair for any fistula patient, for any abscess patient, the best painkiller is getting back to his normal routine. Physical activity, yoga, gym, exercise, walking, running. Next day we make the patient do it, so that the pain is reduced. Then, when I do primary sphincter repair for complex fistulas, no stretching, squatting for primary sphincter for 8 weeks, that is 2 months, until it is completely healed. Then post-op antibiotic for a week, analgesics or no dressings. Next slide. So what are the treatment options for fistulas? So many surgeons think, how do you do a fistula? What is this laser? What is this fibrin glue? What is this waft? What is this lift? What is this loft? There are many fancy names running around in the country now, running around in the world. People go to conference, ASA conference, colorectal conference, and come back with confusion. Always, whenever you go to a conference, sit in the conference, you get confused. They put up so many jargons instead of telling simple things over. So what we do in fistula is, even today, if it is a single track only, all those fancy names will work. Invariably, most of the time, it is not a single track. Because what we see as a simple fistula on a clinical examination will be a complex fistula on an MRI scan. What we see as a complex fistula on a clinical examination will be more complex on an MRI scan. So always don't take fistula for granted, thinking it is simple fistula. Because many simple fistulas where people have operated, there are multiple tracks, secondary tracks which are not identified. So if there is one single track, then it is easy to operate. Generally, gold standard followed even today is fistulotomy or a simple fistulas, which is crossing in less than 30% of the sphincters. So next is fistulectomy. That's also in simple fistulas. When there are multiple tracks, when the fistula track is crossing more than 50% of the sphincter, then there is no scope for fistulotomy or fistulectomy. There is a place where we do sphincter saving procedures. All this previous slide. See, glue, no good results. Plug, fistula plug, no good results. Lift, only in single straight tracks. Waft, only in single straight tracks. Cell therapy, no evidences. Fixation, single straight track. Fistula laser ablation with lift, not working. Fistula laser ablation with closure of internal opening, not working. Fistula laser ablation with stop, not working. Fistula laser ablation with proximal fistulotomy. This is the only thing which is working. I will show some videos. And over the scope clip, they put a clip in the internal opening. None of the procedures which are told in the conferences, which are mentioned in the books, will give good results. It will invariably land up in recurrences. Next slide. Simple fistulotomy, open the fistula tract. Yeah, simple fistulotomy, open the fistula tract and completely scoop out all the debris in the tract. Next slide. Next slide. Proximal partial fistulotomy. Whenever you see a very long fistula, a very complex fistula, see, this is the internal sphincter muscle, this is the internal sphincter muscle, this is the external sphincter muscle, this is the external sphincter muscle. Okay, so there, internal opening, it is crossing the internal sphincter, intersphincteric space, and the external sphincter. External sphincter, there is a subcutaneous part, superficial part, and deep part. Here, proximal partial fistulotomy is taking care of the factory of infection, factory of focus of the anal glands, that is the intersphincteric space. So, proximal fistulotomy is go to the internal opening, identify the internal opening, do a reverse probing, cut the internal sphincter up to the intersphincteric space, sometimes superficial part of the external sphincter muscle. So, that is proximal fistulotomy. In fact, this gives great results because you are destroying the whole factory of infection, the focus of infection there, the internal opening. The internal opening has to be always addressed in any fistulas in your. One of the reasons of recurrence is not addressing the internal opening. Next slide. See, these are the various probes I have, got it customized for myself from a, goldsmith. I called it of a goldsmith and told these are the kind of probes I require. You will never find this kind of probes anywhere in any conferences or any shops. Next slide. Newer modalities now is biggest problem in fistula is incontinence. It may be due to gases, it may be due to liquids, it may be due to solid fecal matter. Okay, so incontinence is a big problem. For that, we do minimally invasive surgeries. Okay, but these minimally invasive surgeries, unfortunately, recurrence rate is very high. So, what is the main focus of fistula is when you come across a patient with fistula? Recurrence or incontinence? What do you prefer? If I ask, people say recurrence is better than incontinence. Always. So, what is the aim of fistula surgeries? A balance between recurrence and incontinence. Oh, it's too late, sir. Okay, so balance between recurrence and incontinence is very, very important. Next slide. Next slide. Lift is ligation of intersphincteric fistula tract in the intersphincteric space. It is by Arun Rajana. It is failed miserably in almost all patients that tried initial days. Next slide. This one. Next slide. So you may ask, when you say minimally invasive surgeries fail, what is the next surgery is? Fistulotomy. Complete lay open the fistula, however deep it is, and do a primary reconstruction of internal sphincter and external sphincter. This gives 100% results without any recurrence. So far till date, my primary reconstruction of fistulas have given 100% results. There is not even a single recurrence, nobody believes it. Primary reconstruction with fistulotomy is the best thing to do. Because when you do a fistulotomy, when there are secondary tracts, those secondary tracts can be approached by a laser. Next slide. 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 Right. So you must be hearing in these days laser fistula surgery, laser fistula surgery. Yes, laser fistula surgery works completely when there is a single tract, because you pass the laser probe in the tract, ablate the entire gland. How to do that is properly clean, properly debride, thoroughly wash, and then do a laser ablation. Before doing that, I told you proximal fistulotomy. Internal opening, internal sphincter, intersphincteric space. Until this space you do a primary fistulotomy, the remaining tract you do a laser ablation, single tract. So in multiple tracts, how does the laser work? Lay open the tract completely, you approach the secondary tracts to the tract and do a laser ablation, you will get good results. So laser, it is used only in single straight tract, you get results. Multiple tracts, you will, to ablate the other secondary tracts, you use laser. Next slide. Crohn's fistulas, again a complex thing, difficult to manage. It is always better to push it to a GI surgeon. Next slide. I told about carcinoma, we have reported cases in our institute. Next slide. Next slide. So incontinence after fistula surgery, that's the important thing. So why incontinence is, there are internal sphincter muscle, external sphincter muscle. External sphincter muscle, if you hold like this tightly, This is the superficial part. This is the deep subcutaneous part. Superficial, subcutaneous, and deep part. Subcutaneous, superficial, and deep part. 3 parts. Hold like this, and this is a puborectalis. See, if I cut this, still holding tight. That is the subcutaneous part. If I cut this deep superficial part, still it is holding tight. If I cut this deep part, still it is holding tight. There is some amount of holding here. If I cut this puborectalis, gone, incontinence. So keep in mind, you should know the anatomy very well, where to cut, where not to cut, where to stop cutting. If it is more than 50% of the sphincter muscle, definitely you will have incontinence to gases and liquids. So when you cut the puborectalis out, incontinence, at least in 3 months, 1 case of incontinence we get. And don't think surgeons do these mistakes. It's not done by surgeons. It's done by quacks, Bengalis. Next slide. So this is Wechsler score of incontinence by Cleveland Clinic. Next slide. So complications of fistula surgery, reoccurrence and incontinence. Incontinence I mentioned. So reoccurrence, why? Not doing MRI scan before surgery. Not properly handling the internal opening, internal sphincter and intersphincter space. Not properly debriding the fistula tract, secondary tract, primary tract. Missing secondary tract. Not diagnosing ulcerative colitis, Crohn's and tuberculosis. Inexperienced surgeon probing wrongly. Once upon a time, even I was an inexperienced surgeon, probed in different direction, created a false tract and did a fistulotomy, came with recurrence. So now I am an experienced surgeon. Next slide. So why incontinence? I told you, cutting the puborectalis muscle in the rectal sling, you get incontinence. Next slide. So myths around fistulas for surgeons. Surgeons think that there are many new techniques for fistulas like glue, stem cell, lift, waft, endoanal advancement flap and clip. They are all fancy. Nothing will work. Please don't even attempt to do all these things. Gold standard fistulotomy, primary sphincter repair. In case you are laser machine, do a laser ablation for secondary tracts and primary single tract. Next slide. SMILES, we have an abbreviation. How to prevent piles and fistula. Stop staining at stools, medication, increase fiber in diet, lifestyle, learning and modification, eat healthy and exercise, say no to surgery with a smile. So we tell all patients this, please practice these things and you don't get piles, fistulas and abscess. Next slide. So these are the patient testimonials, no time. He's from Canada, she's from US, he's from MP, he's from Bangalore. All the complex fistulas, operated more than 5, 6, 7 times, different parts of the world. Next slide. So our fistula stats, authentic, genuine statistics, we have data, 4,648 over the years. In Bangalore alone, 3,652 till date. So we are one of the biggest centers in the world. Not even St. Mark's London, not even Mayo's Clinic, not even Cleveland Clinic. Highest number of surgeries in fistula are done in Spine Institute of Gastroenterology. We do 100 plus fistula surgeries every month as a single institute. Even medical colleges will not do these numbers. Next slide. Okay, last. Now 5 years of experience now, 2 years of COVID. We have done extremely well. Ours is the fastest grown hospital in the country in 5 years. Fastest grown startup in the country. We started with colorectal, now it's become a GA institute. What started as a bottom surgery has gone up to the mouth now. From here we started and came up to the mouth. So it is 22 feet. We are a gastroenterology institute now. And we do the highest number of procedures month on month. Single department, even corporates will not do in Bangalore. Manipur, Apollo, Sparsh Hospital. All put together, we beat them in this particular specialty. So we plan to start SMILE Center in Hassan. Any young, dedicated, dynamic, passionate, committed surgeon who wants to give life, make an impact on this world, can reach us out this number, email. We would love to start a center in Hassan. Next slide. Okay, thank you very much. I just take another 30 seconds. I started colorectal work because I was in deep debt. I was in huge debt in the year 2013. I thought if I do piles, fissure, fistula work, there are plenty of cases I can make more money. When I went there, I realized it's just not possible. It's beyond that. So 10 years of my work, focused work, has fetched us huge dividends. I'm telling the youngsters sitting behind, even if it is simple colorectal, you can make a fortune out of it, provided you focus and give life to the patient. Okay, so this is how I started colorectal work and traveled this distance. So we have a big plan of next 20 years. Our mission is to identify colorectal cancers early and save lives. That 78% should come to zero. So this is our mission. We are starting the world's first mobile colorectal clinic like eye clinics using AI and ML. In our institute, all latest technologies, we use artificial intelligence, we use machine learning for all these cases. So first institute to start AI for colonoscopy is our institute. So thank you very much for a patient hearing. I hope it was not boring. And any questions I can take now quickly for about a couple of minutes. We'll wind up the session. It's getting too late for senior surgeons here. Any questions, sir? Ravi Kumar sir, Dr. Sidram sir? Any questions, youngsters, postgraduates? Okay.
Sir, we'll keep that question over in the later.
Sir.
Very historic labs.
Yes, sir.
Can you open this? You open outside the old concept. And you said you identify the this really.
Exactly.
Yes. That's you open it into the open inside and outside.
Sir, perianal abscess, sir. Ischiorectal abscess which are in these spaces, sir, open from outside. Where outside? In the intersphincteric groove. Internal sphincter, external sphincter. In between there is a groove. You palpate it. There is a depression. In that depression you open.
No, it's not through the anal canal.
No. Anal canal is intersphincteric and anal canal. Inside you drain intersphincteric abscess from inside only. Intersphincteric abscess from inside only. Intersphincteric abscess image. Then supralevator abscess from inside only. Outside what we have done is ischiorectal and perianal in the intersphincteric groove. Intersphincteric space is inside, groove is outside. So this is how we drain the abscess. It depends on type of abscess, where to drain, how to drain.
Few operative procedures can you demonstrate?
Video.
Because this is a common subject.
Sir, I would love to come once again and do a workshop in Hassan. Videos. See, this one, it's a single track. Done the video?
Operative.
Yeah, operative. See, this is the patient from Hassan actually. I operated yesterday. See, Ranjit, no, see, this is the internal opening, internal sphincter, intersphincteric space, subcutaneous part of external sphincter. Only that I am cutting through the cautery. Proceed. Single straight track, recurrent fistula, operated twice, once in Hassan, once in Bangalore, this BGS Global Hospital in Kingeri. See, I am cutting it. You can see the debris there. Okay, now over. That is proximal fistulotomy. Internal opening, internal sphincter, intersphincteric space. Okay. Now I am giving a thorough wash. from the external opening. So this fistula was crossing more than 80% of the sphincter, external sphincter. So this is where laser does magic. See the previous scar you can see here, operated scar. This patient is from Hassan. Now I give a thorough wash. If you don't do a thorough, clean scooping of the fistula tract, you will end up in recurrence. See, this is a brush. Going in the tract. See, it came out. See, I am thoroughly, washing the canal, properly washing the canal. So this is minimally invasive surgery. So unless we wash it properly, we will give a recurrence because of the debris inside. Proper thorough washing with normal saline, betadine, peroxide, use these brushes, and now I do a laser ablation. See, peroxide, betadine. So, a thorough wash of the tract is very, 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 very important in fistula laser surgery. Without wash, surgery will fail. So, this is a laser fistula probe, which is a 360-degree probe. Push it inside, ablate it, and come out. That's it. Over. This fellow walked next day morning. Next day back to these fields for work. Vyavasaya. Hogi Vyavasaya ಮಾಡುವುದು ಒಂದೇ ದಿನಕ್ಕೆ. It's ablating from inside. You can see it coming out of the opening from inside. So that's it. So this is primary and proximal fistulotomy. That is internal opening, internal sphincter, intersphincteric space to fistulotomy. Remaining wash, clean, laser ablation. This is it. Another one. This patient, Shetty, show this scan image. See, sir, notice really. This is the internal sphincter. This is the external sphincter. It is crossing more than 80% of the external sphincter. If you cut here, definitely you will have incontinence to liquids and gases, but not for solid fecal matter. So I have done fistulotomy till here. Internal opening, internal sphincter, and fistulotomy till here. This tract was ablated by laser. Next. Every surgery I have recorded of fistula of mine. I am editing all those things. Very soon it will be available on digital platform. Anybody can watch our videos across the globe. Next slide. See this, sir. See this, how it is. Just one internal opening here. Internal opening here. And there's one external opening here. One external opening here. It was more of a horseshoe fistula. Here again, what I did, go to the previous slide. See, internal opening, internal sphincter, and intersphincteric space. Up to here, I did a primary fistulotomy. Next slide. Next, go to the video. See, external opening here, one external opening here. This is a typical horseshoe fistula which goes in the deep anal space. See, it is coming out here also. That's the laser where I am doing a initial opening of the tract. And you see the probe inside the anal canal. See this one? See how saline is coming out of the other external opening. So these two tracts are connected in the midline, exactly in the beyond the intersphincter space. The beauty of this is, if you deal the internal opening, if you deal the internal sphincter and intersphincter space, and just wash it, not even laser, just wash it, thorough wash, it will heal completely. See, I am going from inside internal sphincter, internal opening, and see the debris there, I am cleaning it up. So this is the tract. From here it has gone like this. From here it has come like this. It used to be video. How many minutes?
2 minutes.
Huh?
2 more.
2 more minutes. Huh? That's all. Otherwise, people would have done a big fistulotomy for this, big opening, patient in the hospital for 8 days, then again on the bed for another 1.5 months, 2 months. See, I am cleaning the tracts. Both the tracts are ablated in laser. That's it. You can move forward. Now I am putting the laser probe inside. This is for a complex horseshoe fistula where we did a primary proximal fistulotomy and laser ablation. Over 30 seconds. Again, same thing. So this track is ablated, this track is ablated, he is done with the surgery. 11 seconds. Go to the next video. This is pylonodal sinus. Again, pylonodal sinus also we operate in the same way. No flap surgeries, no rhamboid flap, no Z-plasty, no keratosis. Any amount of flap surgeries you do, there is always a recurrence. Instead of doing a major surgery and getting a recurrence, it is always wise to get a simple procedure and get a recurrence. So this is pylonodal sinus. Again, same like fistula, we treat it, thoroughly wash it out, and with fistula scope, VAF scope, we remove all the hairs and do a laser ablation. Next video. That's it. Treat like fistula. Next video. Intersphincter. See, sir. This is the intersphincter, sir. See, there is no external opening here. There is only intersphincter fistula here. Internal sphincter, external sphincter. In between the sphincters, internal sphincter. There are two tracks here. We approached from internal opening and did a fistulotomy here. You can go up to the levator. You can completely cut the internal sphincter muscle, lay open the tract inside. Show this. See, sir, I am coming only up to the intersphincter space. I am dividing it in laser probe fiber. So there is no external opening here. There is only internal opening. Track was coming up to the intersphincter space. I have got an opening there now. See, now I probe it inside the. See, you can see the debris here. Here, see, I am pushing the die so that when I open it, I should be able to see the track. See, this is exactly the space. See, I am pushing the probe here. I am pushing the probe and do a fistulotomy by using harmonic so that there is no bleeding and have the field clear. See, I am exactly in the track and doing a fistulotomy by using harmonic. So, in the intersphincter space, I am cutting the sphincter muscle now. This is the track. In the track, I am going, in the intersphincter space, I am going, and probe is going up to the levator. See? How many more seconds? 40 seconds. So this was a track inside the anal canal, intersphincter space. Just lower the track inside and do a proper debridement. That's it, and leave it. You can see the dye there, sir. Next slide. That's it. No more video, right? Primary repair.
Transmitted fistula.
Transmitted via this repairer. I am asking that. Primary repairer. Primary repairer. See this one. This is again crossing the sphincter muscle more than 80%. Transmitted. Sure. Next. See, and it is also in the sphincter space. Very complex in nature. Next. See now, see it looks so simple. The external opening is very close to the anal burst, this one. For any person who sees this, it's a simple fistula. But when it is scan, it is crossing, going up and coming, transmitting almost near the levator. See? I am going in the external opening, reaching the internal opening, doing a primary fistula using the cotton. So, you show the debris, sir. Yeah, until then you can fast forward it. See this is the fistula. Okay. See this, you saw the muscle, sir. Sphincter muscle complex. See? See, it's going deep high up. So I have approached it there, and from here I am going there. See? See, I am cutting the muscle. See, this is the muscle I am holding, the sphincter complex muscle. So I am ensuring that I am not damaging the tuberorectalis. See, this is the complete sphincter muscle complex. Subcutaneous, superficial and deep part. So this is the deep part, this is superficial part, and the subcutaneous have already done the fistula. After doing a fistulotomy, I am putting the sedum for this person. This is a cutting sedum. Okay, this is a pharmacist from Mysore. So this cutting sedum, every third day I tighten it. I don't wait for a week. And you keep on tightening it and it will be off one day. That's it. Primary repair. So this is the sedum one. That's it. See the muscle. I'm tightening it on the muscle using only cutting set. This is the best cutting set in Pune. So this was also a recurrent fistula, doing extremely well, completely healed. Anal manometry was normal. Next slide. Primary repair. So we did sedum one, we did laser one, we did intersphincteric fistula one, we did final root sinus one. Primary repair. Not there? No. This is primary. Primary is missing, sir. I'll share some videos with you. I have a personal number. Okay. Any questions? Senior most surgeon asked me the questions. What about the youngsters sitting behind?
They'll ask afterwards.
We'll wind up.
Once it starts.
Yes.
Then we get more challenge.
Thank you, sir.
So thank you very much for giving the opportunity, sir. My respects to all the senior citizens here. Thank you very much, sir. We need your blessings to grow much more. Thank you.
Thank you, sir, for such an informative session. Now I request Dr. Rajana, sir, Director, Teams Hassan, to hand over a bouquet token of appreciation for Dr. Parameshwara, sir.